this ferris and then to see how things are going. So the patient was started on vitamin D and he was reassessed after 4 months. And what happened at that time is that the calcium normalized and vitamin D also normalized, but it's still the patient is having hypophosphatemia, is having high PTH and high alkaline phosphatase with a little improvement in the PTH. So now we remain with this. Our patient is still having hypophosphatemia, high PTH, and high alkaline phosphatase. Also, we try to combine things together and to see how can we move for the next step. So, is this hyperparathyroidism, is it primary or secondary? It is very unlikely to be primary to us because the patient is having normal calcium, normal ionized calcium, and normal urinary calcium. It could be secondary hyperparathyroidism. As you know, for a long time, when you have vitamin D and calcium deficiency, this might cause some hyperplasia of the parathyroid, and this might need time to resolve after correction. So now we thought that this is probably secondary, and probably the high alkaline phosphatase is secondary to hypophosphatemic osteomalacia. So we remain with that this patient probably is having primarily hypophosphatemia, and we want to dig deep and to see what is the cause of this hypophosphatemia. And here, one of the causes of hypophosphatemia is redistribution, and this is basically shifting the phosphate from the extracellular to intracellular fluid, and this occurs with insulin therapy, refeeding syndrome, hungry bone syndrome, and this is not the case in our patient. So the other cause is that decrease in the intestinal absorption, and also this is not the cause because the patient is not having any features that suggestive that he has got any GI problem. And the third thing is vitamin D deficiency, and this is also not the cause because the patient is vitamin D replete now and is still having severe hypophosphatemia. So we remain with the last cause is that this patient might be losing his phosphate in the urine. So what are the causes that lead to increased urinary phosphatic secretion? These are primary hyperparathyroidism. And as I stated earlier, this is very unlikely. The second cause is vitamin D deficiency. Also, this is unlikely as we repeat the patient. And the third thing is that this is, might be a hereditary hypophosphatemic rickets or osteomalacia. And this is also very unlikely in a 73 years old patient, and there is no any family history suggestive of rickets or osteomalacia. And it could be Fanconi syndrome, and we did thorough workup and we excluded Fanconi syndrome. So we remain with that this patient might be having oncogenic osteomalacia. And what is the first step? The first step we did that is that we prove that this patient is losing the phosphate through the kidney, and we did the fractionated excretion of phosphate, which was found 29, and the normal is less than 5. So this patient is probably losing the phosphate through his kidney. So now, how can we prove that we have a tumor? So we went for the tumor in its place, and we did daughter knock, PET CT scan, and this showed that there is intense uptake located in the soft tissue posterior to the right humeral head. After that, we did a regional image, which was MRI, and showed that there is an ill-defined, very small lesion, which was related to the right teres minor fibers. So we proved that this patient probably has this oncogenic osteomalacia. So brief words about oncogenic osteomalacia is that, or tumor-induced osteomalacia, it's a very rare paraneoplastic syndrome, and the symptoms of this syndrome are rather non-specific, like what is occurring in our patient, that these patients report bone pain, muscle weakness, and gait disturbances, and it manifests with hypophosphatemia as what occurs in our patient. It can manifest also with osteomalacia, fragility fracture, and rarely it can manifest as a lump. And these all of these are occurring in our patient. The biochemical pattern of these tumors are usually that of low serum phosphate, low or inappropriately normal activated vitamin D, elevated FGF23, which is a tumor marker, and increased phosphatic secretion in the urine, as what we have proved in our patient. So what is the fundamental pathology of this is that these tumors, they produce the FGF23, and this causes hypophosphatemia by two things, because it reduces the expression of this transporter, which is called the sodium phosphate transporter, and this is responsible of phosphate reabsorption from the kidney. And the second thing, also it reduces the expression of 1-alpha hydroxylase, which is the enzyme that used to activate vitamin D25. So by these two things, it causes hypophosphatemia. So these tumors are usually very small, and usually they are found in odd places. This here, it is buried inside the distal femur. Here it's in the hand, here in the mouth, in the stomach, and here in the brain, and here in the vertebral body. And what is the treatment of these tumors? Usually the surgery is corrective, curative, and sometimes it might be ablated by microwave, ultrasound, or laser. There is some medical therapies that which are used for the treatment, like phosphate and vitamin D. This is just to replete the phosphate, and there is divergent result in the literature regarding the efficacy of somatostatin agonist-based therapy for this tumor. And lastly, this year, the FDA approved the borosomab to treat these tumors, and borosomab is FGF23 monoclonal antibody. So our patient, we started him on treatment. We started him on vitamin D and phosphate. He is still bedbound, and but he reports that the muscle weakness and these things a little bit improved. And despite phosphate supplementation and vitamin D, serum phosphate is still not controlled, and we didn't even touch the lower limit of normal. We are waiting for orthopedic opinion for him, but he represents a very high surgical risk because he has got multiple vertebral fracture and he has got dead sickness, and likely and cannot tolerate any anesthesia. And that is all. This is shukran and thank you.
Thank you very much, Khalid, for that very, very interesting case presentation. Ian, would you like to make some comments?
Thank you, Ntobeko. Thank you, Khalid, for an excellent presentation.
Ian, are you on your video, please?
A video. Bear with me. I'm not much to look at, but irrespective, thank you very much, Khalid, and thank you, Ntobeko, for allowing us to present this case. Khalid, you've done a superb job. Just to highlight, this is a very rare condition. So I wouldn't like the audience, the 60 participants, to come away thinking that they will likely encounter this patient. But I think the take-home message is, you know, if this patient were to have received inadvertent zonindronic acid, bisphosphonate, by virtue of his osteoporosis, it would have made things decidedly worse. So I would like to appeal to people to at least consider the possibility that calcium and phosphate are important analytes to measure in order to consider a secondary cause for low bone mineral density, such as osteomalacia. We do encounter osteomalacia from time to time, especially in the setting of people who are taking anticonvulsants and who are profoundly vitamin D deficient. And there's a cohort of patients who have this entity of hyperphosphatemic osteomalacia, which is a genetic disorder. Quite clearly, in the case of Khalid's patient, this patient had no genetic predisposition. So it was something that occurred spontaneously. So I think that the bottom line for the audience is to keep an open mind when they encounter patients with low bone mineral density that it could be due to osteomalacia, in other words, the deficiency of the mineral component rather than osteoporosis. And if these people were given bisphosphonate therapy, then it's highly likely that the bone mineral density may worsen.
Thanks, Ian. So what are your plans for your patient? What will you be asking the orthopedic surgeons to do?
Khalid, would you like to respond?
Yeah. As I stated in the presentation, that the best modality of treatment for this tumor is surgery, and whenever this tumor was removed surgically and it is removed by a safe margin, as is stated in the literature, by 0.5 centimeter, this is usually curative. And the other resource of treatment like ablation therapy or medical therapy, these are usually usually given for the cases which are not candidate for surgery, or there is surgery failure, or the patient didn't go for surgery. So if our orthopedic colleague help us and take it out, most probably this will be end of the story.
And is Porosumab available in South Africa?
No, it's not available.
There's a question from Vernon Lowe. Vernon?
Thank you, Ntobeko, and thank you, Khalid, for a very interesting presentation. Maybe just to note, for interest's sake, that there may be a much more common cause for this picture, not in this particular patient, but in general, and that is the excessive use of intravenous iron. So intravenous iron is extremely safe, but it's been well reported that in particular types of IV iron specifically, there's increases in the IFGF23 levels, which leads to hyperphosphatemia and vitamin D deficiency. And you actually get the exact same picture that you've been describing here. And the treatment is very much the same, except for, I don't think the monoclonal antibody is relevant there. But nevertheless, it's just something to think of, because although IV iron is very safe, some people have given huge amounts. I know in one case where a patient presented with multiple fractures and osteomalacia, they'd given 28 doses over a 24-month period, which is clearly too much. It is true, though, that many patients who get some forms of IV iron can have this picture that lasts for 4 to 6 weeks, but it's usually not as severe. Thank you.
Thank you very much, Vernon, for those comments. So thank you very much, Khalid. That was a very, very interesting and well-delivered presentation. So we're going to move to the second presentation of the day, which is by Dr. Nontobeko Matenjwa, who is presenting on behalf of the Division of Hematology. And the title of her talk is rather critically a leaky tap. Please go ahead, Nontobeko.
Thank you. Good afternoon, everyone. Today I'll be presenting on a case of hereditary hemorrhagic telangiectasia entitled a leaky tap, referred to us by Prof. Ross and Dr. Masikati on the G floor. This gentleman is a 51-year-old male from Guguletu who had, at first glance, an unremarkable medical history, presented to Mitchell's Plain with severe symptomatic anemia and a history of this worsening recurrent epistaxis. His 4 blood counts showed a profound microcytic hypochromic anemia, which was attributed to severe iron deficiency. Clinically, he was rather well, except for these strange lesions on his lips and tongue, which he noted had been there since his early 20s. He had some features of heart failure, but only on the milder side of things. He also noted that he had previously gone to KTC and was diagnosed with iron deficiency, but defaulted follow-up over the festive season at the end of last year. He also remembers that in his 20s, he was treated for iron deficiency back in the Eastern Cape. Further history reveals that he had this epistaxis since childhood, which was quite intermittent but became more persistent and a daily occurrence since May 2017. The relevant family history that we found was that his sister had an ischemic stroke at the age of 45 without any apparent risk factors. So at this point, the working diagnosis was that of HHT, and he had a chest X-ray that was relatively unremarkable with just some cardiomegaly to note. And then we decided to do a full body screen with a CTA that showed some abnormal vessels in the brain and the liver and a small area of some arterioportal shunting. His pulmonary vasculature was, however, normal. He also had gastroscopy, which showed some telangiectatic lesions in the esophagus and stomach, as well as an ulcer. Based on this, we clinically made a diagnosis using the Curacao criteria for HHT, with the patients having 3 of the 4 criteria: epistaxis, telangiectasia, and visceral lesions. HHT is present in about 1 in 6,000 of the European population. There's no data in our context available. It's an autosomal dominant disease with variable penetrance and expression, meaning that no 2 HHT patients are the same, even though they may be related. There are more than 600 documented mutations, but the common ones are endoglin, ALK1, and BMP9. And these are found on the vascular endothelial wall and make a complex with the SMAD4, influencing the signaling. These mutations result in reduced signaling and the promotion of vascular endothelial growth factor and inhibition of endothelial cell proliferation, making these very strange vessels and telangiectasia and arteriovenous malformations. A common way in which these patients present is with iron deficiency and iron deficiency anemia, and it's very important to treat these patients adequately. It's commonly due to this leaking tap, which is the epistaxis, more so than the GI lesions that may be present. If inadequately treated, these patients have worsening complications with venous thromboembolism from a reactive thrombocytosis. They're worsening high output cardiac failure and arrhythmias, as well as the risk for ischemic stroke goes up. With the iron deficiency anemia, we prefer to treat with IV iron. If the patient presents at an earlier stage when they're just plain iron deficient, oral supplementation is adequate enough. And then it's a matter of controlling the epistaxis using systemic therapy. It's important to note that we treat the ferritin here and not the HB. So the patient needs iron more so than a massive transfusion. And if you were to transfuse blood, to do so 1 unit at a time, aiming for ferritin levels of more than 100, and the HB will correct itself with the correction of the iron deficiency. The epistaxis is a major cause of morbidity for these patients, and it's a nearly daily occurrence. ENT review is very pertinent to assist with the local therapy, and during the drier months, normal saline drops have been proven to be quite efficient in these patients. Systemic therapy is used as a second line, with tamoxifen being the most well-tolerated and well-documented of these agents, followed by tranexamic acid. These agents typically tighten the grip on this leaky tap, making the epistaxis less frequent and a smaller amount. The hot new drug in the systemic therapy line is bevacizumab, which is an anti-VEG agent. It's been proven in the randomized controlled trials that it's more beneficial in patients who have accompanying pulmonary AVMs with high output cardiac failure and pulmonary artery hypertension. Another common way that the patients may present is with pulmonary AVMs. It's present in 50% of the patients, and they do announce themselves but are often silent. It's also important to note that about 40% of all patients with pulmonary AVMs have HHT. This right to left shunting causes this chronic hypoxemia, and patients may have features thereof. They're also at risk of this paradoxical embolism, which is a complication of these strange vessels. So they may present with a TIA, cerebral abscesses, embolic strokes, and ischemic strokes. In the group that is pregnant with HHT, the pulmonary AVMs grow and are often associated with quite severe pulmonary hypertension, resulting in hemoptysis and hemothorax, and are a major cause of maternal death. Other AVMs to note are the hepatic AVMs, quite common in the HHT population, but often silent. They present late in the later stages of life, typically after the 5th decade, with high output cardiac failure from arteriovenous shunting and post-capillary pulmonary hypertension, as well as portal hypertension and its complications if there's arterial portal shunting. GIT telangiectasia is less commonly seen, and often these lesions are quite small and don't require treatment. If there are any angiodysplastic lesions, during scope, some simple argon lasering usually relieves the problem. It's important to note that in the subtype SMAD4 mutation, these patients can present with clinically significant GI bleeding and often have juvenile polyposis and are at higher risk for GI cancers in the later stages of life. Cerebral AVMs are present in 1 in 10 of these HHT patients and are often silent, quite small AVMs, but when they do present, can be as simple as a migraine and as catastrophic as a fatal hemorrhagic stroke due to these high flow shunts that are created, which results in circulatory overload and hydrovenous dysfunction. So this is just a schematic diagram showing the different vascular beds affected by these arteriovenous malformations and how they eventually cause pulmonary hypertension and cardiac complications, especially from the hepatic side. So the screening has been suggested by the European Reference Network for Rare Vascular Diseases, which specializes in 5 diseases, including HHT. Pulmonary AVMs due to their common and quite severe complications should be screened in all patients at diagnosis using CT or contrasted echocardiography. Thereafter, you'll screen every 5 years or with new symptom development. In patients at diagnosis who originally had quite severe high-risk case, they, with any new X-ray changes, will be screened quite frequently and with immediate effect. Hepatic AVMs are to be CT'd and never biopsied. There have been many case reports of fatal bleeds from biopsy of these livers. And patients with high output cardiac failure or a combination of hepatomegaly, a bruit, or some abnormal cholestatic enzymes are the ones to be considered for screening. Cerebral AVMs are not to be screened unless the patient is symptomatic. They're often quite small and not for intervention. The other problem arises in that an MRA, once a patient has had intervention, will not be able to discern whether there is an improvement or worsening of that AVM. Another important clinical factor in treating patients with HHT is anticoagulation. It's always a tight balance between coagulopathy and bleeding. In high-risk periods when patients go elective surgery, for example, or will be immobilized, these patients require prophylaxis. And the agents of choice can be quite simple as warfarin and heparin versus the DOACs. They've been proven to be better just because of their reversibility. But if patients or the practitioner prefers to use a DOAC, apixaban is more safe than rivaroxaban. But as with all medications nowadays, it's important to individualize to the patients and review the cases quite frequently. So for Mr. JK, he initially received quite a massive transfusion and also got IV iron. If we follow this algorithm over this side, he became better with the symptomatically in terms of his anemia. He had an ENT review for an elective septal dermoplasty, which we will get later on in the year. He's also received some genetic counseling and review of his sibling, especially of the sister who appears to have had quite a complicated course. He also needs further investigation of his hepatic AVM to check whether the cardiac involvement that he presented with was early cardiac failure. He was due to receive bevacizumab, but due to his good response with the tranexamic acid, we opted not to give that therapy as it comes at quite a high price tag, as Prof. Blockman will concur. So the take-home messages are that HHT is a clinical diagnosis due to the genetic variability and the variability in the presentation. The cornerstones of treatment are of that of the epistaxis and the iron deficiency and anemia related to that. That will improve the quality of life for the patient quite dramatically. And the risk of thromboembolism is worsened in the case of the iron deficiency anemia. So you want to get a good tight grip on that leaking tap. It's also important to screen for visceral involvement if the patient is symptomatic and treat accordingly before complications arise. Thank you very much.
Thanks very much, Nontobeko, for a fantastic presentation. Beno?
Thank you very much, Ntobeko. Thank you, Nontobeko. Great presentation. Again, really appreciate your efforts in preparing this. I think there's a couple of general things to learn here for all of us working in medicine, and I think for any doctor, basically. This patient presented with an HP of 1.9, and in my experience, there's something interesting about patients who come in with HPs of 1 or 2. And the one important thing to look for, if they walk into your ward or they walk into the hospital, they are got a dramatic so that's a case where you must be can easily be transfusion over volume. Sometimes give an exchange transfusion in cases like this is really necessary in that setting. But if the patient is stable, just keep them quiet and calm. Give them iron, or the most common cause in my experience for a low HP like that is actually B12 deficiency. Give them their B12. They're going to start responding within 48 to 72 hours. Very good. And you can often get away without a single transfusion. So just keep that in mind. So this is just a general comment for patients with very low HPs that walk in. The second comment is, you can see that this really affects all of us. We want to really set up a center for HHT within hematology, and we're working on that at the moment, but it's really something that can appear anywhere. And all of us, if you hepatology, neurology, general medicine, please keep a lookout for these patients. The interesting fact, another interesting lesson that reminds us of what we're doing in general, is that these patients have a 50% increased risk for developing breast cancer. And that is attributed completely to CT scans and invasive procedures. And it's a reminder to all of us that these things are the radiation that is associated with CTs and angiograms and things like that is not negligible. So I just thought that was a sort of a useful thing. Nontobeko mentioned the interesting fact that there's an increased risk of venous thromboembolism. And they've shown that they have increased levels of factor VIII and shortened APTT times, and which is worsened when they're also iron deficient. So again, just an interesting fact that despite the bleeding issues, we must remember to give them prophylaxis if they go for orthopedic surgery or similar things. So my final take-home message is, in the time of COVID, take off the patient's mask and look into their nose and mouth if they present with any of the features you've heard today. Thank you.
Thanks, Beno. Graham, did you want to ask a question?
Sorry, and Ntobeko, that was from the previous talk.
Oh, sorry.
It was a great talk. I learned a lot. Thanks.
Any other questions for Nontobeko? If not, we'll move to our final presentation for the day, and that's by Dr. Robin Shelley, presenting on behalf of the Division of Nephrology and Hypertension. The title of the talk suggests that it should come with an age restriction. It's called Forbidden Fruits. Over to you, Robin.
Thank you very much, Prof. So today I will be talking about a presentation that we saw during my rotation in renal. It's a case that we found particularly interesting, especially in the strange times of lockdown. And as you said, the title of my talk is called Forbidden Fruits. So we saw Mr. MB, who is a 35-year-old male who's unemployed with no known medical comorbidities, who presented to False Bay Hospital on the 1st of June at 9 p.m. He presented with a history of ingesting a homemade brew, and he was amongst 10 friends. So on admission, he was hemodynamically stable, apart from having a tachycardia of 118. His GCS was 12 out of 15, but other than that, the rest of his examination was unremarkable. At about 3 a.m. in the morning, his condition deteriorated and his GCS dropped to 9 out of 15. He had a repeat gas that showed a worsening metabolic acidosis with a pH of 6.8, at which point he was intubated and ventilated for airway protection and started on IV normal saline, thiamine, sodium bicarb, and he was also given 20 grams of an ethanol solution. At Grooteskier ICU, he was hemodynamically stable, not on inotropes, with a persistent tachycardia, but was noted to have a good urine output of 600 mils and was also ventilating well with SATs of 99% at a FiO2 of 0.4. He was started on thiamine, pantoprazole, clexane, propofol, and morphine sedation. In terms of his blood results, just to note that he did have some renal impairment. His initial creatinine was 99. The repeat creatinine at Grooteskier went up to 128. He had a normal potassium, but to note that he had a metabolic acidosis from when he presented originally to False Bay Hospital, and it had persisted, albeit improved a little when he presented to Grooteskier Hospital. In addition, we calculated an anion gap for him that was 28. He had a calculated osmolarity of 314 and a serum osmolality of 316. So just with regards to the anion gap, basically that is a calculation where the measured anions are subtracted from the cations. The normal anion gap is between 8 and 12, and the anion gap basically represents unaccounted for anions such as phosphate, sulfate, and the anion component of certain organic acids. If the anion gap is raised, you have an increase of your unmeasured anions, accounting for a greater negative charge than normal. So this is just a diagram that nicely depicts what represents really the anion gap in its equation. But more importantly, on the top right, there's a very important buffer system in the body that I'm sure we all are familiar with. And basically, just to explain how it works, is that when you ingest an organic acid, or even if you have, for whatever reason, increased production, you have an increase in your hydrogen ions and your anions, leading to an increased anion gap. And as a result, your sodium bicarb is decreased in a result to buffer the raise in those anions, which leads to your high anion gap metabolic acidosis. So commonly, examples of organic acids that will cause this is your lactic acid, formic acid, oxalic acid, as well as your keto acids. So just with regards to causes of a high anion gap acidosis, so a very useful mnemonic that I'm sure a lot of us have heard before is MUD PALS, and that just summarizes a few of the causes of a high anion gap acidosis, which are methanol, uremia, DKA, parahaldehyde, iron, lactic acidosis, ethylene glycol, and salicylates. So moving on to the osmolar gap, that is another equation where the calculated osmolarity is subtracted from the measured osmolality. So the normal serum osmolality is between 285 and 295. And the osmolar gap, if raised and if more than 10, is used to detect osmotically active particles that are not normally present in plasma. So on to the real topic of today's presentation, and it is methanol, and it really is the alcohol you should never drink, not even a sip. So methanol is one of the parent alcohols. It is very similar to ethanol, whereas ethanol is drinkable and for some people, I'm sure, considered very tasty. Methanol is relatively deadly. It's commonly found in antifreeze, in windshield wiper fluid, in industrial solvents, and biodiesel. So after ingestion, methanol is rapidly and completely absorbed. It follows zero-order kinetics, and as little as 15 to 30 moles is associated with lethal toxicity. Populations at risk include children, industrial workers, and again, in our setting, with the very strict restrictions that were placed on alcohol sales as a result of the lockdown. Other situations where it is commonly found, well, not commonly, but can be found in, is suicide, homicide, as well as in recreational use, especially in people that tend to brew their own homemade alcohol. So in terms of the pathophysiology, methanol and ethylene glycol, as I said, are parent alcohols and are relatively non-toxic. The problem comes in with its metabolism and its oxidation via alcohol dehydrogenase in the first step of its metabolism, and then aldehyde dehydrogenase in the second step of its metabolism. After oxidation, toxic metabolites are formed. So with methanol, formic acid is formed, and with ethylene glycol, glycolic acid is formed. And these are responsible for the lethal and toxic side effects that we see throughout the body. In terms of the clinical features, there's much overlap between methanol and ethanol. Methanol has 4 stages, and just to note that in the first stage of both methanol and ethanol toxicity, it mimics ethanol intoxication, where patients can often appear inebriated and have very vague gastric symptoms. In methanol toxicity, the second phase is a latent phase, where often the inebriation resolves and patients can be asymptomatic. And that is then followed by stage 3, where patients actually develop visual symptoms in the terms of blurred vision, blindness, can develop seizures, coma, cerebral edema, and herniation. With ethanol glycol intoxication, just to contrast, from stage 2, they start with early myocardial dysfunction, and in stage 3, they often present with renal failure. So this was just a study that was done in China, and it was published in the BMC Nephrology Journal, looking at acute kidney injury and the risk of mortality in patients with methanol intoxication. So the study actually showed that in patients that ingested methanol, 33 of them had acute kidney injury, and those with acute kidney injury were older, habitual alcohol users with mostly unintentional ingestions, and that they also had a higher incidence of respiratory failure. The outcome was that acute kidney injury was associated with a 20-fold higher risk of inpatient mortality in patients that ingested methanol. So on to management. The mainstays of management is rapid recognition that the patient has potentially ingested either methanol or ethylene glycol, and the initiation of early treatment, specifically in the forms of inhibition of alcohol dehydrogenase to prevent the formation of toxic metabolites. So looking at inhibitors of your alcohol dehydrogenase, we have ethanol. Advantages of ethanol is that it's cheap, it's readily available, it is effective, it has a 10 to 20 times higher affinity to ADH versus methanol. In South Africa, we only have ethanol available. The issues, however, with ethanol is that a loading dose needs to be given at 0.6 grams per kilogram. After that, serial ethanol levels need to be measured to maintain the patient's serum ethanol concentration between 100 milligrams per deciliter and 150 milligrams per deciliter. And this needs to be done in an ICU setting. In first world countries, they have access to fomepizole, which is a competitive inhibitor of ADH. The advantages include that it's very easy to administer. It's got more predictable pharmacokinetics, and it's got a very favorable side effect. What does limit its use in South Africa is that it is incredibly expensive. So it costs about $1,500 per dose. And just other drugs that we can use just to facilitate the metabolism of toxic byproducts. So in methanol, we can use folinic acid, and if that is not available, we can use folic acid, and that is to enhance the formate elimination. And in the case of ethylene glycol toxicity, we can use pyridoxine and thiamine to enhance your glycosidic acid toxic metabolites. Sodium bicarb is also used, especially if the pH is less than 7.3. And the reason behind that is because a normal pH keeps the toxic metabolites in their ionized state, which means that that they are less likely to penetrate tissues. So the role of hemodialysis is that it removes the toxic byproducts, it reduces the length of hospital stay, and it is incredibly cost-saving. So indications is any patient with a history suggestive of ingesting either ethanol, ethylene glycol with the anion gap of more than 24 or raised osmolar gap with a metabolic acidosis where the pH is less than 7.3, where they also have features of either coma, visual changes, or renal failure. Another indication is having a methanol or ethylene glycol level, and that's more than 50 milligrams per deciliter. But in our setting, it's very difficult to get these levels, especially getting them on time, because not all labs do routine methanol and ethylene glycol testing. So tips and tricks really, and what we've learned from this case is really to have a high index of suspicion. Unfortunately, there is a lack of confirmatory diagnostic testing for methanol and ethylene glycol. So some of the tips and tricks that we can also use is looking at the urine via microscopy, and sometimes we can see these beautiful calcium oxalate crystals that often occur very early in ingestion, and when we see these crystals, it's very suggestive of ethylene glycol ingestion. Another test that we can use is the lactate gap. So ethylene glycol, its toxic metabolites, glycolate and glycosylate, is structurally very similar to lactate. So when we measure the lactate on the blood gas can't differentiate between the toxic metabolites of ethylene glycol and lactate. So on the blood gas, we get a falsely elevated lactate compared to when we send it to the lab, where we actually get a true lactate because that is measured by lactate dehydrogenase. So an elevated lactate gap is also a nice, useful indicator that you could be dealing with ethylene glycol toxicity. And then just in terms of the use of the osmolar gap and the anion gap, so this is a nice diagram that really shows how the osmolar and the anion gap changes throughout the stages of toxicity. So very early in ingestion, when you've ingested the parent alcohol in the form of methanol or ethylene glycol, the osmolar gap is high and your anion gap is low. Throughout the course of it becoming metabolized into its toxic byproducts, the osmolar gap actually goes down as the parent alcohol is metabolized, but at the same time, the anion gap is increasing due to the increase of the toxic metabolites. So a lot of studies have actually said to use serial anion gap measurements to help see what the response to treatment is. Of note, the osmolar gap is very useful, but only very early in ingestion. And there are very few things that can actually give you an osmolar gap of more than 25. So outcome, our patient was referred to the friendly renal on call, and he was dialyzed. After the first session of dialysis, he had a very good urine output of over 2 liters. He had a resolving metabolic acidosis. His serum osmolality was 360. And on the 4th of June, after the second session of dialysis, he had a urine output of 1,200. His blood gas had normalized, and his serum osmolality had also normalized. During admission, he was diagnosed with optic neuritis and had an ophthalmology consult. And he was successfully extubated and discharged on the 5th of June with impaired vision, but he will live to tell the tale. So outcomes, the case actually made South African News 24 headlines. So of the 10 that ingested the homemade brew, 6 actually died. Of the 4 that lived, 1 was completely asymptomatic. 3 presented to Groote Schuur Hospital and were left with permanent visual impairment. And there's an ongoing investigation with regards to the circumstances leading to methanol ingestion. Thank you very much.
Thanks, Robin, for that fantastic presentation. Bianca?
Yeah, I just wanted to say thank you to Robin for the presentation. It was excellent, and just also to have to mention that the management at Victoria was excellent as well. They was treated with high dose fluids, with bicarb, with ethanol as well, and the outcome would have been a lot worse if this hadn't happened at Victoria. Just to mention, the timing of this was really quite tragic because these guys presented the weekend before the alcohol ban was actually lifted. So this and when I did a bit of research on the side, I thought that methanol was quite hard to get a hold of. It turns out that you can actually buy it on Gumtree, and it's really easy to get a hold of, which is quite scary. I've checked with our laboratory here, and there is no assay that they can do for methanol or for ethylene glycol. There is a lab that can test it up in George, but the time frame would be too long to get the results back. So I just want to echo what Robin has said, that you need to have a high index of suspicion, and to start treatment early with ethanol fluid and with bicarb. And if you're not winning and your pH is less than 7.3, then consider early referral for dialysis, because as Robin mentioned, there is no access to the fomepizole in SA. So really, that's all I had to say.
Thank you very much. So Robin, do you know how your patient got hold of the methanol?
We're still not sure. I'm not. Well, we spoke to him, and he wasn't actually sure how the brew was made. He had actually purchased the brew from another person who had made the brew, and him and his friends had put money together to get hold of this home brew to ingest together.
And do you know what the mechanism of the optic neuritis or eye injury is?
So basically, it is as a result of your formic acid. Formic acid is a mitochondrial toxin, and it is very toxic to both the retina and to the basal ganglia. So often in these patients, you often can also have ischemic damage to the basal ganglia, as well as hemorrhages. And there have been case reports that even survivors post-methanol toxicity have a Parkinson-like syndrome due to mitochondrial damage to the pentamen.
I'm going to invite Mark Blockman and then Wazi to comment. Mark, go ahead.
So thank you very much. Just to say that gas chromatography can be done. Sorry, to Red Cross Hospital have a laboratory, And if we know quick enough, we can ask them to do a run, and they're quite careful to do that for us quite quickly if there's any doubt that we need to do that. There's two reasons why methanol, and they are following up, and I was involved in the Department of Health are looking at this quite closely. There's two issues. One is it's clandestinely bought, because methanol is far cheaper than alcohol. So if you're making clandestine different types of liquors, methanol is very cheap, and that's often what happens, is that they buy big drums of methanol. But when you brew, there's a risk when you're brewing as well, if you get it wrong, especially from pineapples, which is what in fact has been occurring lately, is you can convert into acetone or acetic acid, acetone, as well as methanol. And if you don't get the scientific formulations right. And they think that this is the two explanations. My gut is that they've actually bought clandestine methanol in drums, and they've been using this to actually either dilute out the beer that they've got, and then repackage it for sales with the taste of beer, but with methanol, unfortunately, in it. And I do agree the Victoria Hospital people did a brilliant job, and then obviously the referral basis. The Omeprazole, unfortunately, is a Section 21, and by the time we even consider getting it into the country, it's going to be too late. So we're stuck with intravenous alcohol or alcohol via the nasogastric tube in these patients. Thanks for an excellent case.
Thanks very much, Mark. Kwazi, please go ahead. I think you are muted, Kwazi. Maybe you need to turn the volume up on your speakers. No. Can anybody else hear Kwazi? We can see you.
No.
Oh, I'm very sorry about this. Well, we'll end on Mark's note, and just remember not to purchase pineapple beer, even if it's coming from a close friend. Thanks to the presenters for excellent and instructive cases, and we will see you next week. Keep well. Bye.